and thank you to the organisers for inviting me to give a little bit of feedback. So I volunteered to go out with WHO, the Global Outbreak Response Network. Part of my motivation was knowing the founder of GORN, Dr. Mike Ryan, and he's one of our own. And also I had visited and worked in Liberia during the Civil War 20 years previously. I didn't really have any expectations where I was sent. And it was very challenging and difficult, but in a different way to Gabriel. The WHO role was to support to control the outbreak through the various measures, leadership, coordination, and addressing the key areas. And my role was to support coordination at local and national level. And local level was the city of Monrovia and the county of Montserrado. And I worked both in the WHO office and the Ministry of Health, and then as part of your coordinating role worked and went to the treatment centres and laboratories and to communities and outreach. And this is the sort of picture you see of the WHO strategy. There's so many different boxes there, and you think, gosh, there must be hundreds. There weren't. There were about a handful in country. They were there for polio originally in the WHO country office, and about 30 when I was there. And the ministry, I could show you an organogram of the Ministry of Health, but it was large blanks. And Monrovia, the city of Monrovia, the blanks were even larger. People had gone, they weren't there, and this fragile state, as it's called, had not fully recovered from the Civil War. So this was the treatment facilities, 2 treatment facilities, 1 laboratory, at the 20th of August, the day I arrived. And the status of the outbreak at the end of August, it was very clearly acknowledged it had outpaced anybody's expectations. Practically all the counties were affected, and when I arrived there was approximately 450 counted cases. Within a week we were counting up to 1,600 because we were getting better data. And we had a very high proportion in healthcare workers. And the projections then in WHO were 11,000 in 6 months, and others were 100,000. And we'll see how we fared. And these were the priority interventions. You can see right up there at the top was the dead bodies, as well as the treatment units. And quarantine didn't work. Just before I arrived, the President had imposed quarantine in West Point after some riots, and it was the most devastating thing to do because these people were locked up in an area like Dunleary Pier with only one road. So the message was that it was real, and that really was reflected everywhere you went. You felt that people began to feel it was real and you can survive and know the signs and symptoms. And then there was a quick phone, 4455. So my job as epidemiologist was to understand the data, and that was very difficult. And that's the majestic statistics house. And it was very comforting when I arrived to see Dr. Moses Massacoy was the head of case management, and I had worked with him in Malawi in the HIV program, and he had volunteered to leave his job with the Clinton Foundation, which was quite a comfortable job. And he worked day and night, and you know, it is a huge personal sacrifice for the handful of doctors that are there, and that's our triage, which was very useful. And this is how case investigation took place. And again, a lot of stigma in the community. People would turn up and be present when you ask questions, several members of the family. No room in the treatment centre, so a local politician bought his own private ambulance and promoted himself, the Honourable Joseph. People were scandalised because, of course, they were putting on PPE all the wrong way, but I thought, you know what, that really gets it up there. The media have it then. And my job was to support the data in the treatment units, and we tried to apply some science of where the other new treatment units would be situated. This is an MSF treatment unit. You can see this very high, heavy PPE, and it was hot, I can tell you, it was very hot. And this is the spraying and triage, which also can be sad. People arrive during the night and are dead by morning. Some of them don't make it. And this is where they wash the PPE, which I think was great. But then that's where we get a lot of this devotion to what I used to call over-the-top PPE. Then some of the treatment units weren't so fancy. This was the second one, the ministry one, which was in the old cholera ward of John F. Kennedy Memorial Hospital. and that was the exit. You just stuck your foot into that basin of water. That's the incinerator. This is mid-August on the left, the ministry receiving donations, and then by early September, loads of cars. Anyone who's worked in a developing country will know you'll know your crisis when you can't get into the Ministry of Health compound for all the cars that are lined up. And then getting the new treatment centre, so that was a huge emphasis. We knew this was desperate, and so there was this incredible sense of let's get things done. So this was rebuilding an old converted private hospital, and then the laboratory started off in the National Laboratory, then CDC Canada. We had to try and marry the data, very difficult. And this is their mobile laboratory in the MSF Elwa, and then moved to a house, which is quite nice. And burials. I thought burials were getting too much attention until I really realised how important burials were. Dr. Pierre Fomenti in the WHO really pushed this issue, and we tried to develop a standardised form for burials and just, put in place the plans for a commemoration ceremony, because a lot of people are buried without names. We had to work to expand the crematorium, because the crematorium was only there for the Muslim population, which were a minority. So it was a huge change in burial practice, and try to respect the dead. And then you can see the number of burials and cremations by week, going up into late September. And the distribution of time, because some people weren't buried for days after dying, and that was a real problem in the community. And there's the county health coordinator, Adolphus, who was a physician assistant. He was my counterpart. But he wasn't just my counterpart, he was the CDC epidemiologist counterpart. And everybody wanted a piece of him, and there was only one of him. And this is a health facility, Redemption Hospital, closed. Mothers go in there in labour, die. But now it became a holding centre. So the hospital was closed, but we had to look for other alternatives. And the biggest one was, as well as the ETUs and the burials, was the social mobilisation and the community. You cannot end this outbreak without the community. And I don't know if anybody recognises the doctor here. Ian Norton, he's the lead at WHO for designing treatment centres. I think he worked here. He's an ER physician based in Darwin. I'm sure he said he was in the matter. He said to say hello anyway. And these are the Ebola boys. So lots of music, lots of song. And I can assure you, I think the people of Liberia are very resilient. They have come through a lot worse. They've come through Charles Taylor, Civil War. This is the peak, I think, I hope. We thought there's a time lag in the data, and there is a difficulty in counting. The deep green is Montserrat on the neighbouring county. So I just want to say thank you very much, and I'm ending on a note of hope, because the numbers have gone down, the numbers of burials have gone down. Now it could be a blip, but we could be on the right track.